a real-time ultrasound of a woman who is 47, postmenopausal, G2, P2, vaginal deliveries both, with grade 2 to 3 tears, but that was, what was it, 15 years ago. And we're looking at just a suprapubic, somewhat posterior inferior slice of the bladder. You'll see with a clear distinct contraction that the iliococcygeus and pubococcygeus centrally can get a nice lift. I'm just playing with a different kind of angle here. Clear distinct lift and a drop. What I'm going to demonstrate now is asymmetrical straight leg raise. This is lifting the left leg, and this is lifting the right leg. And you can see with lifting the right leg, that fascial prolapse on that right side increases just a little bit more. This is now asking for a pelvic floor contraction with a concurrent lift. The change you just saw was just a change in angle of the probe. And with a clear, distinct pelvic floor contraction, you can see that with lifting the right leg, which is what just happened, that there's impaired load transfer on that right-hand side.
So this next series is of the same individual in standing, and so it's the same kind of suprapubic view. The density is just a little different because in standing there's just the subcutaneous tissue moves around a little bit and the bladder descends. So this is the resting position of the bladder in standing, and this is an excursion of the pelvic floor during a standing contraction. And the excursion is actually quite significant, partly because of the fascial incompetence, and that will contribute to the descent. So the motor control in this particular individual is pretty respectable. Now we're looking at a maintained standing with a pelvic floor contraction. Now this is standing on the right-hand side, and we can see a little bit of descent. And standing on the left-hand side, the ability to lift is a little bit more respectable. The last thing I'm going to show you is with the cue of a pelvic floor contraction, what happens, and then with the cue of a transverse abdominis contraction, what happens to the pelvic floor. So this is a cue of closing the openings and lifting up and in, and we see a clear, distinct central lift. This is a cue of a transverse abdominis narrowing the front of the pelvis and relax, and we see a little bit of a different in the echogenicity because the abdominal wall is contracting. But again, if we ask for, one more time, if we ask for that narrowing, we don't see any abdominal wall difference whatsoever. So this is an example of someone for whom a transverse abdominis contraction does not facilitate the pelvic floor, and that being able to understand the lift of the pelvic floor and the competence there, and being able to add a transverse abdominis contraction without bulging the pelvic floor would be the most important skill. And if we just ask that client to do a transverse abdominis contraction as is being cued right now, there really is not as effective of a pelvic floor contraction as if we just ask for a pelvic floor contraction.
So what we're looking right now is an anterior-posterior view of the abdominal wall. And right now you are looking at a cross-section of the right rectus abdominis. I'm going to have the client lift up their head, and you can see how it gets bigger. And when you have the client put their head back down, then it gets thinner. I'm going to glide over to the left abdominal wall, and you'll see there's a right and a left rectus abdominis with a little bit of a diastasis in the middle, but that white line of echogenicity is evidence of the linea alba still being intact. So now I'm gliding over to the left rectus abdominis, and I'm going to have the client pick up their head, and you can see the density of that rectus abdominis. And now I'm going to slide over to the left abdominal wall. I'm going to get a little bit more gel, sorry about that. Okay, left abdominal wall, and you can see a number of different things. You can see the probe is at the very top with that convex, curvilinear surface. Then there's a subcutaneous tissue, external oblique, internal oblique, and transverse abdominis. So this is on the left side. So if I ask the client to contract her transverse abdominis, then she can contract that transverse abdominis. And you can see how it just slides back. If I ask her to tighten her core, we get a big global kind of contraction, which is not what we're after. We're looking for just initial sequencing. Now I'm going to ask her to relax and now do a pelvic floor contraction. So she is doing a competent pelvic floor contraction, but on the left abdominal wall there's absolutely no transverse abdominis activity. But if we ask her to do just a localized transverse abdominis, then she can perform that. So that's on the left side. You're going to notice the screen change, and now we're on the right side. So we've got the right side of the abdominal wall, and we see a little bit of a different kind of hypertrophy. In fact, that transverse abdominis on the right-hand side has a little bit more hypertrophy to it. And so now I'm going to ask the client to contract her transverse abdominis, and she can. There's a little bit of internal oblique activity, but she can contract that. Now I'm going to ask her to relax all the way and do a pelvic floor contraction. And again, there's no transverse abdominis activity in this particular individual with pelvic floor contraction. So the name of the game with this is that just cueing pelvic floor contraction doesn't mean there's a valid contraction, and nor does it mean that with a transverse abdominis contraction that there will be a guaranteed pelvic floor contraction.